2, 1.
Hello, everyone. Thank you for joining us for part 4 of today's webinar. My name is Mary Corey, Education Specialist for WorldLink Medical, and I'll be moderating today's event. I would like to mention a few quick items before we begin. First of all, please make note of the features available to you within your GoToWebinar internet browser. In the lower right-hand corner of your screen, you should see the chat box where you can enter your questions to Dr. Rouzier. They will be answered at the end of the presentation as time allows. This web conference is brought to you by WorldLink Medical. We provide evidence-based, CME accredited education in wellness medicine. If you desire a small practice doing bioidentical hormone replacement only, or a medium-sized wellness practice, or a large multi-specialty integrated practice, don't miss the debut of the Business of Creating Health, which will provide the knowledge to an informed decision for the model that best suits your specific needs. Meet with like-minded colleagues and our faculty team of experts and create an action plan to move you in the direction you want to go. This is truly a unique opportunity for one-of-a-kind course. Don't miss out. See our website for details. Today's event is sponsored by an educational grant from MedQuest Pharmacy. We are grateful for the continued support in recognizing the importance of patient and prescriber education in the field of bioidentical hormone replacement therapy. They are true leaders in the industry, and we are proud to be supported by them. Today's speaker, Dr. Neal Rouzier, is a pioneer and recognized leader in bioidentical hormone replacement field, treating more than 3,000 patients almost since its inception in the early 1990s. With over 17 years of experience as an educator and practicing physician and 29 years of emergency medicine experience, he has dedicated his life's work to uncovering the medical literature that supports safe and effective protocols for personalized patient care. He lectures worldwide on the benefits of hormone replacement therapy. He is also the author of Natural Hormone Replacement for Men and Women, How to Achieve Healthy Aging. It is my privilege to welcome Dr. Neal Rouzier for today's webinar from his hometown in Palm Springs, California. Hello, Neal.
Hi, Mary. Good morning, and welcome, everyone. The impetus for this webinar is to help those that have difficulty with peers, difficulty with patients, difficulty with perhaps the negativism about HRT replacement as far as testosterone in men is concerned. I receive daily emails and calls from practitioners that have to deal with peers that don't understand what we do or why we do what we do. And some of them are quite vociferous against the use of testosterone in men. There was a practitioner recently that treated a male patient who unfortunately happened to be married to a female physician who felt that her husband did not require treatment, and she was adamant that the doctor prescribing the testosterone was not following current AACE guidelines and that this patient did not qualify for treatment. And she was just adamant that the patient, her husband, not be treated with testosterone. I can't believe that he's still married to her, but nevertheless. And there's questions on a daily basis because we receive phone calls or emails from our peers that criticize us for prescribing testosterone to men, stating that it's beyond guidelines, they don't need it. For one thing or another, they are just adamantly opposed and against the use of testosterone. So, having said that, let's jump in and look at what the medical literature has to say. So there's some recent criticism or concern about this article that appeared in one of the 7 JAMA articles. And in this study here, they looked at measuring soft plaque with CT scan, which is not very accurate. And what they found that was after 12 months of testosterone therapy, there was an increase in non-calcified or soft plaque. It is the calcified hard plaque that's predictive of coronary artery disease, not the soft plaque. And the way that they measured it with the CT scan is not necessarily accurate, but it is of concern that there was a significant increase in non-calcified plaque. There was no adverse effect from this soft plaque. There was no major adverse cardiac event in either group after this. But because there's this increase in soft plaque, everyone gets upset in thinking that it portends harm or pretends that the plaque is going to grow and rupture or cause more atherosclerosis. And this study, which is a very poorly done study, is sort of held out to negate the last 20 years of studies, of outcome studies showing protection and benefit. So it's so interesting that this increase in soft plaque makes everyone think that hundreds of other studies should be negated because of this increase in soft plaque, which in this study was pretty much meaningless. But everyone wants to hang their hat on the study and ignore all the other literature. I'm in the process of collecting articles that have looked at outcome studies on measurement of intermediate thickness. Those studies that have looked at outcomes from testosterone administration and intermediate thickness all show a decrease in plaque in the group that got testosterone in comparison with placebo. But everyone tends to ignore those studies because of this increase in soft plaque, and we ignore all the past studies looking at beneficial outcomes and decrease in intermediate thickness with testosterone administration just because of this one study, which is very unfortunate. Well, what is the harm in this? The harm is, well, if there's an increase in soft plaque, it portends an increased risk of adverse cardiac events. Well, no, not necessarily. This is a study that was recently published in the Cardiology Journal that looked at coronary artery calcium scores. It's a coronary artery calcium score, the hard plaque, that was predictive of an increased morbidity and mortality. So it's really the hard plaque we should be focusing on and the calcium score, not the soft plaque, nevertheless. And unfortunately, the other article in this series was completely ignored, and this is an outcome study. Well, if there's an increase in soft plaque, it would portend bad outcomes. Well, this study did not. It actually showed beneficial.
Everyone stand by. It looks like we temporarily lost Neal, but he's going to call back in, so hold on.
Is everyone there?
We can hear you.
Sorry, everyone. I do not know what happened. Suddenly, all I had was a dial tone. So anyway, in this outcome study, where they gave testosterone for 3.5 years, we saw an adjusted hazard ratio of 0.6 for heart disease, which was protective. It was interesting for stroke, it was 0.7, and combined cardiac and stroke events, it was 0.6, so it was protective. So not only did we not see an increase in risk, we saw a decrease in risk, we saw protection in spite of the fact that the first study showed an increase in soft plaque. Well, if that portends harm, we did not see any harm in this outcome study, which everyone seems to ignore. Why do we ignore the good outcome study showing benefit and protection? And it boggles my mind that we ignore the positive data and we focus on the pretty much insignificant and not predictive soft data, which doesn't really make any sense. But that's unfortunate. I guess that's the way our minds work. Chris, I'm trying to advance the slide, but I cannot advance it on my end.
Okay, he's looking at it.
Well, we've had 3 webinars without any glitches. Thank you. These findings suggest that receiving testosterone is associated with a low risk for cardiovascular events after 3.5 years. The most concerning potential for harm is in regards to the cardiovascular risk, particularly in old men. The first study, this is a commentary from JAMA, the first study by Budoff shows that in symptomatic hypogonadal males treated with testosterone, there was an increase in coronary plaque volume, soft plaque, seen on CT scan. In contrast, this other paper by Cheatham suggests a potential reduction in cardiac events in men over age 40. So what we're doing is we're extrapolating an increase in soft plaque to be harmful, whereas really an outcome study, and we've got 20 years of outcome studies that show benefit and protection, we ignore that. It's interesting, the final comment from this. If we follow the precautionary principle, we should avoid testosterone until we have enough data to prove its safety. Really? Why do you ignore 20 years and hundreds of randomized controlled trials that show benefit and show decrease in heart attacks and strokes, whereas this one study that did not show any increase in events, you say, well, because of that increase in soft plaque, we should be precautionary and ignore all the other data and studies. Well, this is what's on the other side of the coin, which is my point. If you ignore all those other outcome studies and you do not give testosterone, we're increasing the harm in those individuals that we do not give the testosterone to. If it's protective in all these outcome studies, and we ignore those outcome studies because of an increase in soft plaque that did not show any adverse outcome, that makes no sense whatsoever. And this is exactly what the zealots promote, is that, well, we should really, until we have enough data to prove its safety. If you do not think that we have enough data in all these randomized controlled trials over 20 years, I do not know what study is going to convince you. That's my point. We ignore the studies and the data and thereby cause harm if we don't give it. The precautionary principle of, well, we shouldn't give it until we prove its safety is ridiculous. The safety has been proven in multitude of studies. Well, yeah, there's not a powerful enough study that the FDA requires. Great, but what about all the other studies to show benefit that we're completely ignoring? We have to go on what we already have, and yet we fail to do that. This is a nice summary. This is from 2016, American Journal of Physiology, which sort of explains my point. A wealth of recent studies demonstrated that testosterone therapy in men with testosterone deficiency is associated with an increase in lean muscle mass, a reduce of fat mass, that's both visceral fat and subcutaneous fat, a decrease in waist circumference, improvement of glycemic control, and reduced obesity, all of which are beneficial. Well, you can also argue against that. Yeah, well, that's great that it does that. But what if we gave it and there was some mechanism by which it increased plaque or increased plaque rupture? Well, we don't see that in any study. Testosterone therapy is also associated with improvement in lipid profiles, amelioration of metabolic syndrome, reduction in glycosylated hemoglobin, reduction of inflammatory markers, C-reactive protein, tumor necrosis factor alpha, reduction in systolic and diastolic blood pressure, and the icing on the cake is improvement of sexual function, which is why we take it in the first place. More importantly, testosterone therapy is associated with amelioration of diabetes and reduced mortality. Reduced mortality, not an increase, reduction. What is it that we don't see about that? What is it that we refuse to acknowledge and accept about that? Well, we have to be precautionary. Really? All these studies show reduction in mortality, and you don't want to give testosterone because, why? Because you don't understand the reduction in mortality from these studies? Well, we really don't know. What do you mean we really don't know for sure? What studies do we have? 20 years and multiple randomized controlled trials that show reduction in mortality. Why do we ignore that? I don't get it. I don't get what they don't get. A few studies, well, this is the other side of the coin. A few studies marred with serious methodological and analytical flaws reported between 2010 and 2014 suggested that testosterone therapy is associated with an increase in cardiovascular risk. Key emphasis on few studies, significant flawed studies. Everyone wants to hang their hat on the flawed studies. As summarized in this review, this is a great review looking at the flawed studies in addition to all of the beneficial studies. In this review, a thorough and critical analysis of these studies showed that the risks purported are unsubstantiated, and such studies lack credible scientific and clinical evidence. Everyone wants to hang their hat on those flawed studies. Moreover, recent observational registry studies, clinical trials, and meta-analysis all revealed no increase in cardiovascular risk in men receiving testosterone therapy. Yeah, but there's an increase in soft plaque. Yeah, but there's no increase in cardiovascular risk in any of these outcome studies. Why do we ignore that? In this review, the benefits of testosterone therapy in adult men were explained. The lack of credible evidence suggesting that testosterone therapy linked to increase in cardiovascular risk are discussed. It's a great review of these flawed studies. It should be noted that the literature is replete with studies demonstrating beneficial effect of testosterone therapy on cardiovascular and overall health. Why do we ignore that? What is it about some people that just completely ignore that? I don't get it. It does not make, well, there's not that big study that the FDA's won. None of these studies are significantly powered to that degree. But the registry studies are close to that. And that's what we really want to rely on. What evidence is there other than those few flawed studies that there's harm? There isn't. What about all the benefits? Why do we ignore all those studies with the benefits? It makes no sense. This is a great review article for that. This is another nice review article published in Urology. The authors performed an extensive literature search to examine the association between testosterone therapy and cardiovascular risk. Every study shows this. Similar testosterone concentrations were inversely associated with incident coronary artery disease, the severity of coronary artery disease, and mortality. Where would you like your levels to be? Every study shows low levels predict and portend harm. Every study showed when our levels are higher, it's protective. Every study shows that when we raise those levels, it's protective. Where would you like your levels to be? It makes no sense that we ignore this data and these studies, but some people do. Compared with placebo, testosterone therapy was shown to improve cardiac function, increases cardiac output, decreases ischemia on treadmill testing, improves glycemic control, reduces waist circumference, obesity, and fat mass. Let me address that for a second. What does the cardiovascular world do to reduce waist circumference, obesity, and fat mass? Well, diet and exercise. Right. How's that working out? The last 2 years have showed significant increase in coronary artery disease and deaths. In spite of the fact that we've got all these drugs and medicines and we emphasize diet and exercise, it gets worse. We've done such a great job. And the cardiovascular world completely ignores the source of the problem, which was the visceral fat and the obesity. And they do absolutely nothing to decrease that. Statins do not decrease visceral fat. They increase it. They increase glycosylated hemoglobin and the risk for diabetes. Why? There's several different mechanisms, but the probably most significant mechanism is that it takes your testosterone level and cuts it in half, which will adversely affect visceral fat, which increases inflammatory cytokines. They don't address the fat mass, which is addressed in all of these studies. Based on published data, testosterone therapy was not associated with a greater cardiovascular risk. Conversely, the literature suggests that normalizing your testosterone levels, whatever that means, optimizing is what it should have said, benefits cardiovascular health. Why do they ignore that? I don't get it. Publish additional information and changes in the testosterone therapy guidance have refined the hypogonadal male patient. The FDA has also amended the definition of men requiring testosterone therapy to the following. This is really interesting. I've just shown you all this literature and data showing cardiovascular protection. And what does the FDA do? They try to restrict the use of it. Great. Testosterone is FDA approved as a replacement therapy only for men. This has not been in the past. This is of recent. Only for men that have low testosterone levels due to disorders of the testicles, pituitary gland, or brain. I'm not sure how you even diagnose that. That cause a condition called hypogonadism. Translation, you should only prescribe testosterone to those men that have some sort of pathology and have low levels as a result of that pathology. The FDA has removed the indication for treating men that have low testosterone due to just old age. However, the FDA has become aware that testosterone is being used extensively in attempts to relieve symptoms in men who have low testosterone for no apparent reason other than aging. Well, the FDA has become aware of it. And the problem with that is they don't like it. Why not? We're just going to let the men suffer? Yes. Really? Yes. While manufacturers and providers must take these warnings seriously, many men with significantly low testosterone benefit greatly from testosterone therapy. That's why we use it, to help improve symptoms. Why is the FDA against improving symptoms? They don't like it. Really? Why don't they like it? Well, that's politics and economics. But nevertheless, the FDA is aware of it. Well, that's why we doctors do what we do, to try to help improve symptoms. Let's move on. This is a nice study looking at, it's a randomized controlled trial giving testosterone to men. This is a randomized placebo-controlled trial, and they looked at insulin resistance, carotid intermediate thickness, and C-reactive protein, risk factors for cardiovascular disease. An interim analysis at 12 months showed that testosterone injections, long-acting testosterone undecanoate, improved insulin resistance, improved carotid intermediate thickness, lowered C-reactive protein, in comparison with those that took placebo or received placebo. When they found these results, then all patients were then switched to testosterone injection because of the benefits seen in those that got it in comparison with placebo. Testosterone injections reduced fasting blood sugar, reduced waist circumference, and improved surrogate markers of atherosclerosis in men with a metabolic syndrome. Resumption and maintenance of testosterone levels into the normal range of young adults results in multiple reduction in cardiovascular risk factors in men with a metabolic syndrome. There is no significant hematologic, meaning blood clot in the veins or arteries, and there was no adverse prostate event, i.e. prostate cancer. This is a nice 10-year study. Well, there's no long-term studies. There's lots of long-term studies, and this is just one of those long-term studies. This is a great study. Subnormal levels of testosterone are associated with significant negative health consequences, with a higher risk of all-cause and cardiovascular mortality. Where would you like your level to be? Low and increase your risk of all-cause of death, including cancer and cardiovascular disease, or optimal, upper end of the range of normal for a young adult, which is protective against all-cause mortality, in particular cardiovascular mortality. In a single center study, this is a registry study, which is better than the observational studies, not as powerful as the FDA requires, but a step in the right direction. This is a powerful study in that it was a 10-year study. They looked at waist circumference, body weight, body mass index, and they found that waist circumference, body mass index dropped statistically and progressively with the continual use of testosterone over a period of 10 years. There was a decrease in diastolic and systolic blood pressure, a decrease in C-reactive protein, and there was no major adverse cardiac event in this 10-year study. Testosterone therapy has a number of beneficial effects on weight, fat distribution, and metabolic factors, which the cardiovascular world ignores. Testosterone therapy is a powerful tool in weight reduction and its associated benefits. I read a recent study that compared the weight loss with stomach bypass surgery in comparison with long-term testosterone use. Both of these studies showed significant weight loss, up to 20 kilograms, but there were significant adverse effects seen in the bypass surgery group that we did not see in the testosterone group. And of course, there's tremendous improvement in symptomatology and quality of life with the testosterone administration group as opposed to the group that got just stomach bypass surgery. This is from the International Journal of Endocrinology. This is another great study. Symptoms of low testosterone include, that's why we use it, decrease in libido, erectile dysfunction, decreased vitality, reduced muscle mass, increased fat mass, depression, osteopenia. Hypogonadism is a common disorder in aging men with a significant percentage of men over 60 having low testosterone levels that should be treated. I recently saw a post from a physician who treated a patient, and the patient went back to their family doctor, and the family doctor wrote this scathing letter to the treating physician about now that they've messed up their HPA axis and this patient should never have been given testosterone. Well, how do you treat all these symptoms? How do you improve all these things? Well, they just shouldn't have been treated. Really? We just let them suffer with that. Shame on us physicians that do that. Symptoms and signs of hypogonadism include loss of vitality, fatigue, visceral fat, loss of muscle mass and strength, mood changes, depression, other nonspecific symptoms, loss of energy, motivation, initiative, poor concentration and memory, sleep disturbances, increased body fat, diminished work capacity, loss of motivation in work. That's what happens when we lose testosterone. That's why we treat men. That's why men want to be treated, because we can improve these symptoms. And the FDA wants to restrict it? Shame on them. I wonder how many of them are secretly taking testosterone. In the past 2 decades, several studies have been carried out to determine the benefits of testosterone replacement therapy. The results of these studies indicate that testosterone provides several benefits: improvement of muscle mass and strength. Why would you not want that? Improvement of bone mineral density, a decrease in adipose tissue, visceral fat, subcutaneous fat. Why would you not want that? Why would you want to restrict it? Well, they don't qualify for it. You don't qualify for fat reduction. You don't qualify for decrease in visceral and subcutaneous fat that's harmful. Lipid abnormalities. It reverses lipid abnormalities seen with the increase in visceral fat. Why would you not want that? They don't qualify for it. Please explain to me how you do not qualify for a lower cholesterol, lower triglycerides, and an increase in HDL. Please explain to me why you would not qualify for that. It makes no sense. Better blood sugar control. Why do you not qualify for better blood sugar control? Why would you not qualify for protection against cardiovascular disease? Sexual function, they don't qualify for it. Really? You want to restrict it? Yes. Why? They don't qualify for better. How can you possibly say that? How would you want to restrict that? Improve mood and cognitive function. There was a recent study published in JAMA that showed that giving testosterone to men does not improve cognition or memory. Well, of course it didn't. The dose that they used was so small, the levels went from 300 to 400. But when you look at the studies where we take levels from 300 to 400 and bump it to 1,000 to 1,500, that's where you'll see improvement in cognition, mood, and depression. You won't see it with such small doses. Low testosterone increases dyslipidemia, hypertension, diabetes, and an increase in cardiovascular disease. There's an increase in visceral and subcutaneous fat. Testosterone replacement therapy has been shown to reduce visceral and subcutaneous fat, reduces waist circumference, which should be the goal of every cardiovascular doctor. Do they do that? No. Do they focus on obesity? Yeah, Fred, you got to lose weight. Well, it's not working out, doc. The studies have also noted some positive changes in total body fat, regional fat distribution with testosterone therapy, completely ignored by the cardiovascular world. As adiposity was also noted to decrease along with an increase in lean body mass. It lowers body fat, it raises muscle mass, which improves metabolism. That's what we're trying to do. And the cardiology world gives statins, which lowers testosterone levels, which works against that. We see a further reduction in lean muscle mass and an increase in adipose tissue. It's also been noted that leptin levels correlate with body fat. Leptin levels decrease with testosterone. As we age, leptin goes up, appetite goes up, food intake increases, increase in visceral fat. How do you lower leptin? Testosterone lowers leptin. Why would you not want to do it? Well, they don't qualify. You don't qualify for lowering leptin? I don't get it. And generally, effects on lipids are observed more after oral, and that was oral testosterone undecanoate. I don't recommend that we use that. And with higher dose testosterone treatment, with key emphasis on the term higher dose testosterone treatment. Some studies show that testosterone administration didn't work much. Well, that was because the dose that they used was so small. But in these studies where they use long-term high dose, that's where you will see the benefit. I reviewed a case recently where the physician was criticized for using higher dose testosterone, which resulted in significant improvement in lipids and decrease in body fat mass and waist mass, waist circumference, and body fat. And they only accomplished it with higher dose, but yet were criticized for using a higher dose, and that's what the literature says we should do. We do not see these effects with transdermal preparations, which are low dose. Use the medical literature to guide our therapy. High levels of testosterone have not in any study shown to contribute to the etiology of cardiovascular diseases, just the opposite. Cardiovascular risk factors may be affected by the presence of low testosterone levels, and in every study when we use it and see high levels, it's protective. Yet, we're afraid of doing that for some reason. Low testosterone increases the risk of dyslipidemia, hypertension, diabetes, and the increase in cardiovascular disease. What is it that the cardiovascular world does not understand about this? Well, there's an increase in soft plaque. What about all the outcome studies that show benefit? Why do you ignore those outcome studies? It makes no sense. A small longitudinal study of testosterone versus placebo noted improvements in carotid median intimal thickness. Every study where they've looked at it for outcomes shows a decrease in plaque in comparison with the placebo group. Sexual function goes without saying. That's why we use it. That's why men demand it. It's a shame that there's pushback against that. It makes no sense scientifically. Many studies in younger men have reported improvements in libido and sexual function. A meta-analysis by Isidori reported that moderate improvement in sexual function was noted in men that have levels of testosterone typically below 346. The lower your level, the greater the improvement in sexual function. There was an improvement of mood, an improvement of feelings of well-being, and a decrease in depression. Why would we not want our patients to have that, and why would we not want that for ourselves? They don't qualify for it. Cognitive function. You'll see that there's no improvement in cognition in those studies that looked at a transdermal 1% testosterone gel. In those studies where they used higher doses or injections, you'll see improvement in verbal abilities and cognitive function. This is particularly important to aging men who see changes in their memory and cognition and function, and yet we sort of ignore them. I'm losing my memory, doc. Well, that's too bad. Here, take some more drugs. Sleep apnea. There was a recent study that was published showing significant benefit cardiovascular-wise and outcomes that were improved but there was an increase in sleep apnea in those that took testosterone, which sort of confuses us. Obstructive sleep apnea can increase cardiovascular disease and outcomes. So this study actually looked at that. Androgens play a role in contributing to the pathogenesis of obstructive sleep apnea. When your androgen levels are low, there's an increase in visceral fat. Well, it makes sense. And if we take testosterone and reduce visceral fat, we'll see a decrease in obstructive sleep apnea. And that's what they found in this study. There was a meta-analysis of placebo-controlled trials, and they found there was no significant difference in frequency of sleep apnea between the placebo and the testosterone replacement groups. This is a meta-analysis. Well, there's one study that, look at the meta-analysis. Small studies have actually shown benefit in men taking testosterone that had obstructive sleep apnea. They improved because of the reduction in visceral fat. Having sleep apnea is not a contraindication. Polycythemia. Of course, as everyone that's attended the courses from WorldLink, testosterone does not cause polycythemia. Poly is multiple, cythemia increase in cell count. There's multiple cells that increase in cell count. That's what polycythemia, high white cells, red cells, and platelets. Testosterone does not cause that. It causes erythrocytosis. But zealots will still say, no, the erythrocytosis causes the increase in blood clots. However, we do not see that in any study in 20 years giving testosterone, except for the flawed studies. And don't quote me for flawed studies. It was noted that testosterone intramuscularly increases hematocrit more than the transdermal testosterone. While there's legitimate concerns regarding polycythemia in individuals with testosterone supplementation, there's no clear evidence in any study that there's an increased risk of blood clots, heart disease, heart attacks, or strokes in those that were administered testosterone. In a recent meta-analysis of placebo-controlled trials, we did not see any increase either. In fact, we see decrease. Well, if testosterone truly causes polycythemia, which causes an increase in blood clots, we certainly don't see it in any study. Well, what do we see? We see improvement. We see a protection against blood clots, heart attacks, and strokes with testosterone. Not only does it not cause it, but there's protection against it, which again gets back to polycythemia does increase the risk of those things, but testosterone does not cause a polycythemia. It causes a physiologic erythrocytosis, which is the same erythrocytosis that we see in people that live at altitude that do not have any increased risk either. But nevertheless, the guidelines say if your hematocrit is greater than 54%, hold the testosterone or reduce it or phlebotomize. Why? Because those are the recommendations for polycythemia from the hematology guidelines. So if you have polycythemia, then sure, you're at risk for blood clots. Well, then treat the polycythemia. This is not polycythemia. This is physiologic erythrocytosis. And unfortunately, the hematology world and the cardiovascular world cannot grasp this. That it's a physiologic erythrocytosis. It has not been shown in any study in all of these randomized trials in the meta-analysis of these studies not to show any increased risk. Show me where there's an increased risk. They can't. But you still see that as a guideline. And the guideline, again, is for polycythemia. It should not be for testosterone itself. There's no adverse effect in prostate cancer. There's a multitude of studies showing, in fact, a decrease in severity of the grade in prostate cancer in those men that take testosterone or have a higher level. Potential adverse effects. Well, hair loss. Well, as we see with giving testosterone in men that have levels greater than 200, there's not an increased stimulation of prostate cancer, nor is there an increased risk or incidence of cancer in those men that have levels greater than 200 because of that saturation model. Well, the same thing applies to hair, as I explained in part 1. When you look at the studies, there's no increase in hair loss because your hair follicle is maximally saturated with a serum total testosterone of greater than 200. Adding it or raising it to 400, 600, 800, or 1,000 does not stimulate the hair follicle to fall out any more than a baseline level of 200 does. The Endocrine Society Guidelines recommend that one should have symptoms of androgen deficiency and low testosterone for the diagnosis of hypogonadism. It is true. The FDA defines hypogonadism. I don't know why the FDA defines hypogonadism. Why are they the ones that define hypogonadism? Well, because they defined hypogonadism as serum levels less than 300 on 2 different lab tests and symptoms, they told the Endocrine Society to come up with guidelines. And as a result, the guidelines have changed. The guidelines now state that, and please read the guidelines. The guidelines state, we suggest. They do not say must. They don't say you cannot prescribe it. They say, we suggest that a patient have levels of testosterone on 2 separate occasions of levels less than 300 and symptoms. If you have 2 tests less than 300 and symptoms of a deficiency and a pathology of the pituitary, hypothalamus, or testicles, then testosterone is indicated. Those are the guidelines for the diagnosis of. However, there are some studies that now state that you must have. The guidelines do not state you must have. The guidelines state we suggest. If you read something that says must have, that is somebody's opinion. The guidelines do not state that. Go read the guidelines. The guidelines say we suggest that. Nevertheless, if you still focus on the guidelines that are meant to be restrictive, then you fall into that category of physician that refuses to treat the symptoms based on the guidelines, which is, again, only a suggestion. We suggest that. But can you prescribe testosterone outside of the guidelines? No, the guidelines state that you must have. No, the guidelines don't state that. The guidelines state we suggest. Let's say the guidelines do say you must. Can you still prescribe testosterone for a man that has symptoms but has levels greater than 300 on testing and does not have pathology of their hypothalamus, pituitary, or gonads? Can you still prescribe it? Yes, you can. Where does it say you can? Let's look at this article from the AMA Journal of Ethics and the prescribing of off-label use. Approval by the FDA implies that available evidence shows that a drug is safe and effective for a specific indication or disease or symptom for which it was tested. So based on recent guidelines, the FDA states that testosterone is only FDA approved for treating hypogonadism, which is defined as a blood test less than 300 associated with symptoms and a pathology. Can you prescribe testosterone off-label and it to a man that does not have the specific definition of hypogonadism? Yes. Where does it say it? In the AMA Journal of Ethics. Off-label drug use commonly refers to the prescribing currently available medication for an indication, disease, or symptom for which it was not FDA approved. Off-label also includes prescribing a drug for a different population or age range than which it was clinically tested and using a different dosage or dosage form. That's exactly what we do. Yes, but it's against the guidelines. But you can prescribe outside of those guidelines. Where does it say that? Right here. You can prescribe any drug or medicine for off-label use once it receives FDA approval. Once a drug is FDA approved for a specific indication like hypogonadism, legally it can be used for any other indication. Off-label prescribing is common. It accounts for 10 to 20% of all prescriptions written. I disagree with that. There's articles out there showing that most medicines are prescribed off-label in 50 to 75% of the cases. There are several reasons why off-label prescribing is so common. Well, the drug companies are not going to spend millions of dollars to get FDA approval for every indication. All they need to do is get FDA approval for one indication, and that drug can be prescribed off-label for any other indication, it is legal to do so, and it is commonly done in 50% of the cases that we prescribe medication. It's the marketing of off-label use that the FDA gets upset with, and that's why they've recently spanked the drug industry for marketing testosterone for off-label use. The FDA does not prohibit physicians from prescribing off-label, and Congress has repeatedly taken legal steps to prevent the FDA from interfering with the practice of medicine. Here we go again. The FDA steps in and says, we want to restrict it, and so we're going to make restrictive guidelines. But Congress has said, you cannot interfere with the practice of medicine. You can make all the restrictive guidelines you want. You cannot interfere with a doctor prescribing testosterone off-label to help improve symptoms. Off-label use is appropriate when it is in the best interest of the patient based on credible, published scientific data supporting the use of the drug in that manner. I have given you all those studies and the scientific data supporting the use of the drug to help improve symptoms, to decrease cardiovascular risk factors, and to help improve quality of life. It's in our most peer-reviewed journals that this data exists, and it is perfectly legal and appropriate to use it off-label, in spite of the fact that the FDA is trying to interfere with the practice of medicine. They cannot, and that's why it is legal to prescribe it off-label. I hope that this helps people overcome that fear of prescribing it for off-label use. Off-label prescribing is a common and legal practice in medicine. This practice is justified when the scientific evidence suggests that the efficacy and safety of a medication for an indication for which it does not have FDA approval, and when the practice is supported by expert consensus or practice guidelines, which it is. I hope that gives you comfort and confidence in prescribing it. This is a nice article from Morgentaler that reinforces what I just reviewed in this past article. Testosterone therapy has become highly controversial, yet there's important health consequences of testosterone deficiency and meaningful benefits with treatment. There is level 1 evidence that testosterone therapy improves sexual function, improves sexual desire, body. Concerns regarding cardiovascular risk were based on 2 deeply flawed retrospective studies and are contradicted by dozens of studies showing cardiovascular benefits of testosterone therapy or high testosterone levels. And these are in placebo-controlled trials in men with known and active heart disease. Testosterone is neither scourge nor panacea. It's just good medicine. Thank you, Dr. Morgentaler. The frequently stated assertion that the benefits of testosterone therapy are unproven is simply false. There's level 1 evidence that testosterone therapy improves erectile function, libido, sexual frequency, improves lean muscle mass, improves lipid parameters. It reverses all of the adverse cardiovascular markers. It reduces visceral fat, and it improves glycemic control. Wouldn't it be interesting if we could come up with a drug that did all that? Do you think it would sell? If we could come up with a statin that did all of these things, do you think it would sell? Yet we've got the drug and everyone ignores it or resists it or tries to market against it. Testosterone therapy is shown to significantly improve libido in men. Improvement in erection is also noted for these men. Significant improvements in frequency of sexual activity and orgasm was also noted. Yeah, I wonder how many people in the FDA are sneaking. Yes, that was sarcastic. But it makes no sense with the data of the improvement in quality of life that we ignore that and try to restrict the use of it. Who is a candidate for testosterone therapy? The challenge, however, is in deciding what testosterone level is considered low. Why is it that you have to have a testosterone level? Why is it you focus on the testosterone level? Why is it that you want to make a level so that it's restricted. Why do you want to do that? Because you want to restrict the therapy, but what about the patient's symptoms? They don't qualify for it. You don't qualify. Patients come to doctors to improve quality of life and symptoms and for health. Testosterone replacement does all of that, and yet we want to restrict it. Let me rephrase that. We don't. The FDA wants to restrict it. For the first 40 years after the commercial available testosterone became available, the diagnosis was made entirely on clinical presentation. In part 2, I reviewed this landmark study published in JCEM 1999, where they specifically stated that the administration of testosterone should be based on clinical presentation and symptoms and not on a laboratory test. They go on to say that there is no biological parameter, i.e. laboratory test, that denotes a deficiency. A deficiency should be noted based on clinical presentation and symptomatology and not a number. It is a great landmark article that defines how and when we should prescribe testosterone. Today it's becoming increasingly clear that symptoms and clinical presentation should once again take priority. With blood test results and important secondary confirmation. Well, your level's low. Okay, that's great. Now we've confirmed it. Well, your level's high, but you still have the symptoms. No, you don't get it? You don't qualify for it? Well, what about my symptoms, doctor? You don't qualify. You mean I got to live like this forever? Yes. Really? That's ludicrous. But yet that's what the FDA is trying to do to restrict it. The difficulty in arriving at a reasonable threshold value for biochemical confirmation of testosterone deficiency is underscored by the wide range of recommended threshold offered by various professional groups, which is their personal opinion. And these levels range from 200 to 400. So your level's greater than 400. It's 401. Nope, you don't qualify. You don't get it. But what about my symptoms? Tough. Really? That's just ludicrous. Since there's so much variation in reference ranges across laboratories, one survey actually revealed that 17 of 25 laboratories had different reference ranges. This means that the same lab test result may be categorized by one laboratory as normal and by another one as low. It's the same lab, same reagent, same machine, same everything, but the ranges are different based on what the pathologists want to use. The explanation for the wide range in threshold recommendations is that there's no specific testosterone value that reliably separates men who may benefit from treatment and those that will not. Men can have levels of 700 and will still see improvement. You can have patients with levels of 200 and get the testosterone and they don't see any improvement. The number does not dictate who or who will not respond. Therefore, these threshold recommendations are purely arbitrarily picked and not based on any science. Moreover, there's a substantial degree of inter-individual variability in regard to symptoms and response to treatment. As I just said, some men can have high levels and respond to treatment. Some men with low levels don't respond. Maybe that's because they didn't get enough. Due at least in part by two known confounders. One, binding of testosterone to sexual binding globulin, and number two, the generic variant, when you have receptor site insensitivity at the androgen receptor. You can have perfectly normal levels of testosterone and have loss of attachment to the receptor site, loss of signal transduction, and significant symptoms, even though your level is, quote, normal. It has nothing to do with what your level is. It has to do with the amount of free testosterone that's available to bind on the receptor site sensitivity and attachment, and then signal transduction inside the cell. That's what results in symptomatology, not the number. But everyone wants to hang their hat on this number. This means that healthcare providers must decide on whether a course of treatment is indicated based on the totality of the clinical presentation, i.e. symptoms, rather than a blood test alone. The FDA wants to restrict it AACE guidelines are based on what the FDA told them to put in the guidelines, which is restrictive. In our practice, we found free testosterone to be more clinically useful than a total testosterone, as it is independent of sex hormone-binding globulin. Typically, Morgentaler uses, this is Quest Labs, a free testosterone less than 100, consistent with a diagnosis of testosterone deficiency in symptomatic men. Okay, that's great. So your level's less than 100, we're going to treat you. But what if the level's 101? You don't qualify? What about the level of 150? No, you don't qualify. What if the level's 200 and you got symptoms? Nope, you don't qualify. Really? You're going to restrict improving the quality of life and improving cardiovascular disease based on a number that is arbitrarily picked and not predictive? Yes, that makes no sense. So, as Morgentaler states, the current widespread practice by health insurance companies, including Medicare, to restrict coverage based on a specific testosterone threshold value lacks a scientific basis. It's only opinion of a group of selected experts and is contrary to good medical practice. The diagnosis of a deficiency requires clinical judgment. An attempt to replace this with an irrational adherence to arbitrarily picked values prevents healthcare providers from offering important treatments to appropriately selected patients that are symptomatic. Why do we want to restrict it? What a shame. We don't restrict thyroid, we don't restrict estrogen, we don't restrict other hormones, but we want to restrict testosterone. Men are not defined by their testosterone values. Thank you very much. The clinical presentation is most important. The denial of health care coverage by insurance companies, and I will add on to that, the denial of prescribing from physicians based on requirements to meet specific testosterone thresholds is unscientific and replaces clinical judgment with an arbitrary threshold for an imprecise test, representing a transparent desire on the part of the insurance company and the FDA to deny treatment and thereby reduce costs. This practice should be condemned. Absolutely. Testosterone therapy for men is neither a panacea nor harmful. It's simply basically good medicine. Thanks, Abe. This is another nice journal article from the Canadian Medical Society. Testosterone replacement therapy is appropriate in men with a deficiency syndrome who have cardiovascular disease or at risk for cardiovascular disease. So there's this concern that it increases cardiovascular disease or heart attacks. Well, not based on this study. In fact, it's just the opposite. If you've got cardiovascular disease, you should be on testosterone for greater protection. And if you're not protecting yourself. The authors of each section assessed the literature pertaining to the clinical important outcomes in the respective areas and assigned a grade to describe the quality of evidence using the procedure outlined. In brief, the randomized controlled trials were rated as high quality, observational studies of low quality. The Vegan and Finkel study were observational studies, and they were extremely flawed. We see no flaw in any of the randomized controlled trials. The clinical diagnosis of testosterone syndrome can be challenging because clinicians frequently face situations in which the laboratory results, testosterone levels, remain inconclusive or they're even in the normal range in the presence of symptoms. Well, what do? Well, the guidelines say don't treat them. Just let them suffer. Thus, it has been suggested that the presence of a convincing clinical picture but uncertain laboratory results, i.e. normal lab test, a theoretical trial of testosterone supplementation is an acceptable diagnostic approach. Do you feel better? Yes. I've not seen any man that didn't feel better. Therefore, the goal of testosterone treatment is improvement in symptoms and achievement of eugonadal levels of testosterone in the mid-range for a healthy young man. For those of you that have attended the courses, I've shown you data. The higher your level, even supraphysiologic, provides even more health benefits. A recent study showed that there was no plateau whereby raising higher testosterone levels resulted in no improvement. It was linear. The higher the level, the higher the dose, the continual improvement in symptomatology, lipids, and visceral fat. Because there's large variation between individuals, symptom improvement should be the primary objective. And higher or lower serum testosterone concentrations may be acceptable in patients with a positive response to therapy. If your level's low, raise it. If the level's high, prescribe it. In spite of the fact that the level is high, you'll see symptomatic improvement. It makes no difference what your number is, and all the studies show that. In conclusion, this study found a role for testosterone therapy in patients that have altered body composition and metabolic issues. It decreases visceral fat. There's no other drug that does that. Well, growth hormone does, thyroid does, estradiol does, but they're all hormones. Another nice study looking at vascular health. Men with testosterone deficiency and a history of cardiovascular disease benefit from long-term replacement. This is a registry study, which we'll get into a little bit more next webinar. Because registry studies are so much more powerful than observational studies and are not that perfect study required by the FDA with a long-term use in 50,000 men. But it's a close second. In this study, we investigated the effects of long-term testosterone replacement therapy up to 8 years. And these men all had a prior history of cardiovascular disease. In these men that got testosterone, we observed a significant weight loss, decrease in visceral fat, a decrease in BMI, and an improved cardiovascular outcome. I will end with this study showing that we shouldn't fear giving it, we shouldn't restrict giving it, and even in men with bad heart disease, there's a beneficial effect that we cannot achieve with any other drug. We should not restrict it. And when you see all these outcomes show benefit, I'm sorry, just because there's an increase in soft plaque does not trump all of these other randomized controlled trials and meta-analysis showing benefit in outcomes. That's what you need to look at is outcomes. And we see benefit in outcomes in all these studies. So I hope that was fun. I hope that gives people confidence and credence and medical support for why we do what we do. In spite of the fact that there's criticism against us for doing it, those people who will criticize have no clue or concept as to the medical literature. Those people that criticize and want to restrict it have no clue or concept as to what the studies show as far as benefit is concerned. And when you don't give it and you restrict it, that's when it's harmful. Completely the opposite. Okay, questions?
Can I just interrupt for a moment, Neal? For those of you that have just joined us, please note in the lower right-hand corner of your screen, you should see a question and answer box. Where can you enter your questions to Neal? Back over to you, Neal.
First comment from Rob. Oh no, the anti-testosterone zealots have found a way to try to stop the webinars. No, they can't shut me up. Anyway, thanks, Rob. Thanks for joining. Steve Lassiter writes, are we able to get the specific references for the articles? Mary will take care of that. You can contact Mary or Dana at WorldLink, and they will give you all the references. Again, I cannot provide you because of copyright laws. I wish I could give you all those articles, but I can give you the references, and if you're a member of EBSCO, you can get those entire articles. Barbara writes, I received a nasty letter also from a family practitioner, well, so what's new, who told me that I just cease and desist as soon as possible and not treat patients with testosterone. Okay, well, I strongly suggest that you ignore that letter. You don't need to cease and desist. If you cease and desist and don't treat with testosterone, look at the harm that you're causing. Especially a patient older than 60 years of age. The letter used the analogy of an old car. A car that's 20 years old, would you replace it with a 400 horsepower engine? Sure, it'll work optimally for a while, but then all the other elements of that car will break down because you're pushing it unnaturally. I mean, it's laughable, but see, it's absolutely interesting that, you know, they'll use an analogy like that to say, no, don't use it, but they'll completely ignore all those data and studies that I showed. You know, I've given you enough data, analysis, randomized trials, meta-analysis, outcome studies, and expert opinion to counter whatever your peer recommends that you do. Be understanding of your peers that are zealots that don't understand what you do. There will always be someone who will push back against you. What you have to do is push back using the scientific data and knowledge that what you're doing is absolutely correct and beneficial for the patient. And what they're doing by wanting to restrict it or not use it is harmful for the patient based on all the literature and studies. Hi, Steve. Great talk. Thank you very much. Steve, I was a patient who you started on testosterone therapy 8 weeks ago. There's been improvement in libido and erections. That's good. However, he has an occasional anorgasmia. Most recent testosterone levels were 400 with a free of 47. Would I lower the dose? I wouldn't. Would I add oxytocin? Yes, you can. You can also apply testosterone to the glands, which will help increase sensitivity. We see this on occasion. For those people who say, well, okay, well, you know, made it worse, well, then stop it and then see what happens. Well, it continually gets worse. It doesn't get any better. So, yeah, I would do as I say, apply the testosterone to the glands. You can use oxytocin. I would also recommend using one of the phosphodiesterase inhibitors, which will also help improve that. Lori writes, as always, amazing and pertinent information. Many thanks. Well, thank you for thanking. I appreciate it. Joanne asks, can you tell us again what the landmark article was for testosterone supplementation based on clinical presentation and symptoms? It was the landmark article on, it was JCEM 1999. It's in part 2 of the series. There's 2 landmark articles that were published in JCEM back then. Both of those articles are in that syllabus. Barbara writes, an internist just quoted another case and cautioned me regarding prescribing testosterone. Patient on testosterone was found to have polycythemia, and the testosterone was not discontinued. Instead, he was just phlebotomized, and he had a stroke. Well, that's a nice observation, but observation does not prove causation. When you look at all the other studies and outcome studies in patients, in 50% of patients will have polycythemia, i.e. erythrocytosis. There's a decrease in strokes and heart attacks. So just because a patient had a stroke, and there's lots of patients that have strokes, just because he was on testosterone does not prove that he had a stroke. Patient and is now suing the BHRT Integrative Clinic. I would love to defend that clinic. Once they get my deposition, they will drop the case. Can I again comment, please, on what physicians call polycythemia and blaming strokes on testosterone? Well, unfortunately, the best way to avoid strokes and heart attacks is not to treat any person that's going to be sick. Unfortunately, men as they age get heart attacks and strokes. 95% of men die from heart attacks or strokes. And unfortunately, you cannot prevent that. The only way to prevent it is not to treat. Well, you have to use your medical literature and science and data to support why you do what you do. Just because a patient was on testosterone and had a stroke does not mean that the testosterone caused it. Oh, well, what do they have to prove it? Well, you got 2 flawed studies, which I will knock down. There's thousands of other studies showing protection and decreased incidence of heart attacks, strokes, cardiovascular disease, intermediate thickness, inflammatory markers, et cetera, et cetera, et cetera. So you really need to look at all of those different outcome studies and use all of those outcome studies to support no increased risk, a decreased risk in incidence. And just because one person had a heart attack or stroke, they do happen, does not mean that taking the testosterone caused it. Because when you use all the randomized trials and the registry studies to show and prove that there's protection against, not an increased risk of, and you show that the 2 studies that showed perhaps an increased risk were severely flawed, then you win. Hi, Lane.
Please hold on. It looks like we've lost Neal again. Bear with us while we get him back.
I pushed the pound sign. What else? Okay. Sorry, Elaine. I don't know what happened. There's no genetic marker. There's tests that they do to look at receptor sites, the androgen receptor site that is genetically altered, and as a result of that, it affects sensitivity of the testosterone molecule when it attaches. So it's not an available test. It's just something that they've done and looked at scientifically, which sort of, again, shows that there's intervariability between those that will benefit and those that will not. Dr. Sharma asked if you can get a copy of slides by email. You'll have to contact Mary and Dana for that. Dr. Sharma asked, BPH and testosterone therapy, any benefits? Yes. Most recent article showed no increase in PSA that was significant, no increase in symptomatology. In fact, the meta-analysis recently done shows that testosterone therapy actually improves BPH symptoms and significantly improves symptoms of LUTS, L-U-T-S, which is lower urinary tract symptoms. We've all assumed that because testosterone causes uncontrolled growth of the prostate, I say that sarcastically, it does not, that there's going to be worsening the BPH and symptoms, whereas the literature and the science, when they look at it, and outcome studies show benefit, not harm. So don't worry about it. Men, when they get older, still have BPH symptoms. They still have outflow obstruction. You have to treat that in other ways, but testosterone does not make it worse. And the studies that have actually looked at it, it made it better. Next question, what are my thoughts on using Clomid to increase testosterone 35 to 55, in men 35 to 55? Have I used it? Yes, absolutely I do. That's covered in part 2 of the course. Next question, legally, how can you justify use of testosterone in women? Legally, you use the medical literature, and there's tons of medical studies and data on it. That was introduced in part 1 and part 2 on showing benefit. There is no FDA-approved testosterone, but that does not mean you can't use it. It doesn't mean, you know, all these studies have looked at it. And if you look at those studies, they've used patches, creams, gels, and injections. Increased bone mass in women, yes, absolutely. Improved glycemic control, yes, absolutely. Increased muscle mass, of course. How can you use it legally? I don't know what you mean by how can you use it legally. If it's compounded by a compounding pharmacy, you can prescribe it. If it's available commercially, you can use it. And that's what all these studies did. There's tons of studies. In part 2, I listed, there was a nice review article that looked at probably 20 different articles and the outcomes of those studies showing all benefit. So legally, how do you do it? You use the medical literature to support your use of it. It's quite simple. Next question, Kayla says that she was at a conference where they suggested the use before giving testosterone to keep fertility in younger men. Testosterone use in men will adversely affect their fertility because it suppresses FSH and LH, which then decreases stimulation of the testes and the Leydig cells that produce testosterone and the serotoli cells that produce sperm. So I don't use testosterone. It will absolutely adversely affect fertility, which is why you would then want to use Clomid or HCG in younger men to preserve fertility, and I would not recommend using testosterone. Dr. Sharma asked, clomiphene versus testosterone therapy in younger men. Yes, I would use the Clomid or clomiphene in lieu of testosterone in those that you want to preserve function. Dr. Purcell says, what about anorgasmia in women? You have a patient who states she was started on an HRT and she can't have an orgasm. Well, that's like saying, well, I started on Ambien, but now I can't sleep. Well, most women find, and most studies support, improvement of orgasm and sexual function in those women that use testosterone. So I can't explain that. In part 4, we looked at the use of Pitocin or oxytocin for treatment of anorgasmia in both men as well as in women, and I would suggest using that if you're having difficulty with orgasms. Hi, Dove. It was interesting just today, one of my patients who is an endocrinologist asked for his recent labs thinking that he had polycythemia. Using the tools you've shared over the years, I educated him that polycythemia is not erythrocytosis, and he was happy to understand that. It was interesting, in part 2, we had an esteemed hematologist oncologist attend who said that a recent conference that he went to, they educated the hematologist that polycythemia was not erythrocytosis as it pertained to testosterone. But nevertheless, everyone thinks that it is and thinks that it does. But you have to really look at the outcomes. My past lecture on erythrocytosis versus polycythemia took about an hour. I've now accumulated enough study and research to increase that to 2 hours, unfortunately, which will be an upcoming webinar. There's a lot of data and studies showing that erythrocytosis actually not only does not cause blood clots, but actually will decrease the incidence of blood clots, and it's definitely not polycythemia. But anyway, I will have that as an upcoming webinar. It'll be a 2-hour webinar to look at all of the outcome data and studies and to show why polycythemia is harmful and does cause an increase in blood clot and the pathology behind polycythemia, which is primarily a thrombocytosis from platelets as opposed to increase in blood clots from red blood cells, which everyone assumes that it is, and they assume and extrapolate, but we do not see any blood clot risk in people that have erythrocytosis that live at altitude, and there's 500 million people around the world that live at altitude that have excessive erythrocytosis, and we do not see any increased risk of blood clots in those individuals that have high red blood cells or erythrocytosis. The problem is that we don't understand and we extrapolate and assume, and we can't make that differentiation. Okay, everyone, that's the last question. I hope it was fun. See you next webinar next month. Thank you very much. Back to you, Mary and Dana.
Thank you, Neal. WorldLink maintains an active subscription-based service to EBSCOhost, a third-party aggregate of thousands of medical journals. Please consider supporting this service and join for $350 per year. We'll provide access to Medline as well as folders for articles presented in these webinars and workshop courses. Information can be found under the Membership tab on the WorldLink Medical website. Thank you so much, Dr. Rouzier. I hope our listeners enjoyed it as much as I did. Archived versions for all webinars can be found on the website under Resources and Webinar Library. There is always new information coming out. Think about attending a refresher training if you haven't been in a while. If you're new to WorldLink Medical, we look forward to seeing you at a future event. Thank you again, Dr. Rouzier, and everyone who joined us today. Have a wonderful rest of your day.